Écoutez, je remercie beaucoup les organisateurs de m'avoir.
Well, thank you to all the organizers for having invited me to make this presentation. To start the session on fatigue. And I'm going to try and just talk to you about this problem. How do we define fatigue that's related to cancer? So this is a subjective and persistent feeling of fatigue, of physical exhaustion, emotional and cognitive exhaustion related to cancer and its treatment. It's disproportionate to recent physical activity. So now this is a very frequent problem. 80% of patients under treatment suffer from it. And one sees different reasons: emotional shock, announcement of bad news, a sudden difference in your way of life, affectionate, emotional problems at family level, socio-professional, etc., investigations of stress, aggressiveness of treatment, and then all the hospital schedules. 40% of fatigue also persists in patients who've been cured of cancer and also those in the palliative stage. So there the fatigue levels go up to almost 100%, even 99% of patients in the terminal stage. Now, when we talk to our patients, we find that there are 3 dimensions of fatigue that emerge. Physical fatigue, which is the most obvious kind. Any problems related to making physical effort, problems with food and therefore weight loss. Others also complain about a more psychological fatigue, emotional irritability, anedynia, apathy, sleep disorders, and then others complain about a cognitive dimension. They talk about lack of attention, concentration, memory lapses, somnolence, and a sort of disturbance in their normal rhythm, diurnal rhythm. Now, there's several scales, fatigue scales. You might wonder why there's so many. The best known, for instance, is the Roten fatigue, the QLC fatigue, the American one factor. There's some with 11 items. That's the FQ-BFI, translated into French 9 items. MFI 20 has 20 items, and then the French scale. And there's several others. It's not an exhaustive list. So these scales, I think, are meant for clinical research, because on a daily basis you find that there's a kind of saturation in patients, particularly when they have to keep answering all these scales and so on. Sometimes it's even counterproductive, because there's a sort of hope that awakens in them, when they fill in these questionnaires. But unfortunately, they are disappointed because there's insufficient management of patients. On a daily basis, we use the more digital scales, You code between 1 and 10, and it's an essential tool for screening, particularly of moderate or severe fatigue. And I might remind you that fatigue is part of the 10 symptoms which are regularly assessed in the Hamilton scale. A comment in passing in the difference between fatigue and the general state of the patient. So these are terms that are often used and confused in our clinical practice, though they're very different. Now, a general state is an objective statement of your physical functions. Now, according to WHO, it's a sort of hetero assessment which creates problems, because you'll be assessing the state of health according to what the patient is saying. Now, fundamental questions to be asked are: what is the percentage of your physical activity over the total activity during the day? Can you do your toilet by yourself? This is a simple and essential question which also gives you a better idea about the person's overall fatigue. In files just yesterday, for instance, I noticed that the patient receives help to dress up, even though he's on scale 1. It's very difficult to understand. There's some fundamental rules also that must be remembered. You can't have this OMS being used when the person is in an acute condition or has orthopedic conditions, for instance, a plaster or a respiratory failure. So now this would be useful on a daily basis. The reasons for fatigue, there are several reasons, and that's the whole problem with managing fatigue, particularly for patients displaying many of these symptoms. Very often there's just one single cancer. It's the cancer itself, because it upsets the basal metabolism. Anti-cancer treatment, pain, anemia, fatigue already existing before treatment, comorbidities, lack of physical exercise, insufficient diet, side effects of medicines, depression, and sleep disorder. Now, fatigue is indeed multifaceted. A patient going to be operated will be tired because he'll be given a general anesthesia, which may lead to complications in the post-op stage, for instance, infection, hemorrhage, and so on. And there's also the stress of surgery, both physical and psychological, which is very great. Then there's asthenia also, which is extremely high in the 10 days that follow, which could be cumulative and give rise to anemia, nausea, diarrhea, etc. Similarly, chemotherapy, which leads to daily movement every single day, very stressful, leads to nausea. Also very important for those under treatment, if they are not properly informed or properly educated, this lack of physical exercise is likely to lead to a certain lack of physical condition, and which will lead to greater fatigue, and so it gets into a vicious circle and more fatigue. Now, physiopathology of pain. There are two causes. It is a muscular fatigue related to the disruption of the skeletal muscle, particularly in the sarcoplasmic reticulum of the mitochondria, and which leads to a drop in ATP. And it's also because that it's the basal gland which is involved in the reason to move, motivation of movement, and which might actually show certain dysfunction as far as dopamine and IFN is concerned. Then there's mental fatigue, and this involves the suprachiasmatic nucleus, and which is responsible for hormonal suppression, and it follows a certain circadian cycle. So there's also a drop in the corticoid production, a fall also in sexual hormones, progesterone, testosterone, and DEA. So clinically, here's an exploration of fatigue. I'm, of course, referring to the AFSOS recommendations, and they have given this sort of table for use on a daily basis. Now, after the clinical examination, if there are no obvious reasons for fatigue, like denutrition, depression, pain, comorbidity, then the recommendation is to carry out a biological check, including cortisol dosing, albumin, TSH, magnesium, vitamin D, CPK, and liver function, as well as a lung X-ray, sonography, similarly of the abdomen, and maybe a heart scan, an ESR, an ECG. Now, if the cancer is in remission, fatigue still remains, and so there would be a screening also of a possibility of relapse, of sequels like depression or organic diseases and others, and of course a biological check to look for exactly the same thing: cortisol, magnesium, vitamin D, CPK, and so on. Now, according to the NCCN guidelines, we have this sort of table which recommends the use of a simple digital score for fatigue and no additional investigation, but just some suggestion on education, that is how to prevent fatigue, particularly for mild fatigue between 0 and 3. But if it's 4 and 10, then you consider a management depending on the stage that the patient is at, either follow-up, end of life, or under treatment. So there'd be education on fatigue and a certain therapy, mental therapy. We will also be looking for all causes that can be treated for fatigue and use perhaps some sort of psychostimulating treatment. Now, to treat a curable cause, I needn't give you a list of others than those which are not related directly to cancer, because I think someone will be speaking about it. Now, supportive therapy. This is extremely important, and you could even call it behavioral therapy. Always listen to the patient, who would feel relieved to describe what he's feeling. Help to find adaptive strategies, or coping, as we'd say, to cut down his aims and objectives in terms of physical exercise and do something else, change point of view, etc., which would require less energy, and explore representations of the same. After fatigue, it's extremely important. How does he explain this fatigue? Is it for him something that expresses the seriousness of the disease? Or is it maybe a sign of a failure, a setback in any kind of treatment? Or is it that the tumor has really not been properly detected? So all these ideas have to be explored in order to reduce any misapprehension. Plus, of course, education regarding lifestyle, certain healthy lifestyle, food, sleep, and so on. So all this is not one shot. In fact, this is over a regular basis, and progressively you talk about it to encourage and motivate the patient and give him the advice that he or she requires. So I've picked these studies to indicate this sort of management, which show the impact of supportive care in order to improve their quality of life. The Zimmerman study, which you heard about, was published this year in The Lancet. Prior to that, it was Bakitas in January. You've got the names now here. Each time, these were nurse consultations or with other members of the profession, psychologist or a social worker. So there was a sort of coaching that was started to do a proper therapeutic education. This was part of the NE2 project. This is repeated, and it's honestly this sort of service that provide a demonstrable efficacy and to improve, of course, fatigue, amongst other things. Now, as far as therapeutic as far as the therapy is concerned, it especially concentrate on physical activity. There are different kinds. There's normal physical activity, adapted physical activity, so which is a way of getting back on one's feet, particularly if the physical condition has highly deteriorated. So the idea is to go through 3 or 5 sessions of 20 to 60 minutes per week, which improves not just the quality of life, but also survival if you're in complete remission. We have this study, for instance, shows that there is a gain of 8% when there is a program and appropriate physical activity, plus a vegetable and fruit-rich diet, enriched diet. At the Curie Institute, if I might, we have, for instance, a program, active program, for patients in complete remission. And this includes workshops on physical education, on food habits and diet. In addition to all that, there are other options too. Now, there's very little methodological trial. There's the American ginseng, for instance, but the Barton trial, for instance, is rather criticized for its methodology. Now, acupuncture, certain trials were carried out by Moliasiotis against a placebo, says that you can't really forget about acupuncture. Yoga also shows a certain benefit published by Buffat, but not strong enough, not high enough to have a major impact on quality of life and fatigue. Now, certain other drugs like modafinil have not been proven formally to have an effect. This latest study by Spatis at the GCO in June, over 208 patients suffering from non-small cell lung cancer. They were given 5 milligrams and then 200 milligrams up to 28 days. First 14 days, then 28 days, show a major improvement in quality of life according to the FACET scale in both the arms with the placebo effect. Similarly for methylphenidate. Now, the Cochrane review by Minton showed that there's a probable effect, in fact, of this drug, but the latest by Brewer didn't confirm it. 141 patients who had all sorts of different cancers, and again randomized, double-blind, placebo-controlled. They were given methylphenidate at lower milligrams, 5 to 20 milligrams maximum per day. There was really no difference on the 15th day. So in conclusion, these therapeutic trials must be continued with new drugs which have still not been used for fatigue management. Maybe there's some hope, particularly for targeted therapies. Then there are several options there, but what's really important is that we think of modeling, in fact, fatigue management and of any kind of supportive care. Now, when it comes to this assessment modality, we have to work with the hospital, in fact. We should be doing it. So do we need to have specialized nurses coming for consultation? So that would be a sort of delegation of power by doctors towards nurses. Now, that's quite feasible since the new HPSC law has been ruled in, plus also some programs related to therapeutical education. There are quite a few studies which are in favor of this kind of management to improve fatigue and quality of life. Thank you.